We are going to come to an era of biomarker-driven therapeutics. So right now, it's very limited in myeloma. It's the 11-14. That's the biomarker-driven group of patients. And maybe that will expand that into the BCL2 high patients. But for the rest of the majority of the patients, there isn't a biomarker at the current time. We're going to look for more biomarkers, and we're going to find some. So that's going forward. But in that other population, and for me, I always tell patients the options, that the groups of triplets that actually are associated with the longest progression-free survival. But I go through the other, maybe perhaps more convenient options, the all-oral options versus the subcutaneous injection options versus the IV options. The other thing that I didn't mention in the talk today that is gonna, I think, make a big difference is daratumumab has shown in a randomized phase 3 trial that the subcutaneous administration of daratumumab, which actually takes 5 minutes, versus the IV infusion of daratumumab, which the first dose can be 7 to 8 hours, subsequent doses can be 4 hours, or if you do the rapid infusion at your institution, it could be 90 minutes. But still, at the lowest, 5 minutes versus 90 minutes, it's a big difference. Once daratumumab is available by subcutaneous injection, I think then it's going to even be or have more widespread use in the early relapse patient population. And probably, it's about how well the regimen responds in that group of patients. And most of the triplets are responding quite well. It's almost pick your triplet of interest, and so what we do is we do this ping pong approach. If I did daratumumab, pomalidomide, and dexamethasone for first relapse, I then would go to a carfilzomib based regimen for second relapse. Maybe carfilzomib, Cytoxan and dexamethasone, or carfilzomib and panobinostat and dexamethasone, but carfilzomib in a different combination. And it actually works really quite well.